Good evening, everyone. Thank you so much for joining us tonight. We're just going to give everybody a moment or two to log on, and we'll begin shortly. Okay, good evening, everyone. Thank you so much for joining us tonight for common urologic conditions and what to expect when seeing a urologist with our presenters, Alfred Winkler, MD, MBA, who's the Chief of Urology in Brooklyn, Jonathan Gall, MD, who's the Assistant Professor of Urology, and Lynn Motanya, D.N.P, who's the Nurse Practitioner. We encourage you to submit your questions in the Q&A section. Tonight's session will be recorded and sent to all those who registered. And it is now my pleasure to turn things over to Dr. Gao.
Hi, thank you so much. Good evening. Um, so we're going to start with a little bit about myself. My name is Dr. Jonathan Gall. I trained in Israel, where I completed my residency in urology. My partner and I moved to New York about 2 years ago, where I completed a fellowship program in male infertility and sexual health. I joined faculty at Cornell earlier this year, and I'm seeing patients on the Upper East Side. I do see both male and female urological issues, but my main focus is sexual health. So today we're going to talk about erectile dysfunction. We're going to review anatomy. What is erectile dysfunction? Causes, diagnosis and workup for erectile dysfunction in clinic, and treatment options. We're also going to end with a little talk about vasectomy. What does it mean and how do we do it? So a little bit about erections anatomy. To cover the basic anatomy, the penis is composed of two main erectile bodies called the corpora cavernosa. They are enveloped by a double layer tunica albuginea, which gives the penis its strength and pretty much its shape. During stimulation, through a cascade of events through the nervous system, the smooth muscle in the corpus cavernosa is relaxed, allowing for more blood to flow in and enlarging the corpora. That causes a compression of the venous plexus against the tunica albuginea, stopping the blood flow out and a trapping of the blood. The trapped blood with a tunic allows us to get a rigid, hard erection. So what is erectile dysfunction? It is defined as the inability to attain or maintain an erection that is sufficient for satisfactory sexual performance. And I think satisfactory is a very important point to look at. Not all patients and all people want to have the same kind of sexual activity. Some people are okay with different things. So it's important for us to be aware where the patient wants to go, where their partner wants to go, and adjust our expectation accordingly. So a little bit about erectile dysfunction. It is prevalent in 30 million men in the US and over 150 million men worldwide. There are many risk factors for erectile dysfunction. Age and smoking are both independent risk factors. Hypertension is a risk factor, with approximately 35% of men with hypertension have some sort of erectile dysfunction. Dyslipidemia, high blood cholesterol and triglycerides are also associated with erectile dysfunction. Diabetes is one of the most common causes of erectile dysfunction, with prevalence ranging from 20% to 85%. Cardiovascular disease and erectile dysfunction have mutual atherosclerotic causes. Many times, erectile dysfunction is a first symptom, requiring a patient to undergo a thorough cardiovascular evaluation. We'll discuss that later. The International Index of Erectile Function questionnaire is a basic questionnaire allowing us, me as a physician, and you, the patient, to understand where you stand. It covers 5 topics: confidence, rigidity, durability, ability to climax, and satisfaction. High score is considered better erectile function. Using it in initial workup and in follow-up visits allow us to understand where we started, where we're heading. A lot of patients want to know what happens in clinic. I think erectile dysfunction is one of those topics that patients don't really feel comfortable talking about sometimes. It's important to know that our clinic is a space and you can talk about anything that you want to talk about. I think a lot of patients find comfort in bringing their significant other. Some don't, and that's okay. It's really a personal preference. And you can also not bring them to one visit and bring them to the next. Prior to your visit, you will fill out an IIEF score, which we discussed in the previous slide, and a medical questionnaire. We will review your full medical, sexual, and psychosocial history, and a full physical exam will be done with a focus on penile and genitalia examination. The primary visit may include some laboratory work. We're looking for hormone abnormalities, a hemoglobin A1C as a marker for diabetes, and a lipid profile. In some cases, you will be referred, as I said, to see your primary care physician or cardiologist to ensure that there's no underlying cardiovascular disease. Follow-up visits may be short just to see how things are going, but they may also include a penile Doppler ultrasound. You can think about it as a stress test to your penis. Inducing an erection with a small injection to the side of the penis, the Doppler, an ultrasound, allows us to evaluate the blood flow in, blood flow out, trapping of the blood during an erection, and also perform a curvature assessment if one is necessary. We may also go through intracavernosal injection at home and train you to do that there. So treatment options, what can we do for erectile dysfunction? So like many other fields of medicine, I think the first thing that we can do is change our lifestyle. Patients find it quite cumbersome and hard sometimes, but it's also very important. So weight loss, smoking cessation, alcohol reduction are all associated with improved sexual function. Exercise and diet are also important for that. I want to talk about a topic that is a bit different, psychogenic ED. It's a diagnosis that we usually made after excluding the other problems with erectile dysfunction. It means that someone is too stressed, has too much adrenaline in his blood flow to allow himself to get a full erection or maintain it. Usually that needs to be treated by a third-party specialist or a sex specialist to discuss why this is happening. One of the more challenging aspects of erectile dysfunction is what we give you as physicians for other illnesses. So two main medications that cause erectile dysfunction, I'm sure you've heard of them, beta blockers and thiazide diuretics. As urologists, we can't recommend to stop them in order to achieve better erections, but we can definitely talk to your primary care physician to get a more penis-friendly alternative medication if that is possible. Sometimes it isn't, and it's just something that we need to work with together. Oral therapy. I'm sure you've all heard of PDE5 inhibitors. The most famous ones are Viagra and Cialis. These medications stop the breaking of a cyclic GMP, which is a small particle that allows the smooth muscle to stay relaxed for longer, allowing for a better erection with more blood flow into the penis. Viagra, known as sildenafil, needs to be taken an hour before sexual activity on an empty stomach, while Cialis, tadalafil, it can be taken as a low-dose medication every day or 2 hours prior to sexual activity. There are a few more, but I won't go through them today. You can definitely talk to your physician if you're interested. Intracavernosal injection or injection of medication into the penis directly, it bypasses the nervous system. It is done with a small needle similar to an insulin syringe. There are 3 different options with different variations of medication. The common one is Trimix, a combination of Pavarin, phentolamine, and alprostadil, also relaxing the smooth muscle and allowing for a better, harder erection. When managed correctly, it can be used in a long-term fashion without any complications. The main thing that we are concerned about is causing a priapism, which is a prolonged erection of over 4 hours, which requires treatment in their emergency room. A vacuum device, a bit of an odd device, causing a negative pressure over the penis, drawing blood into the penis and using a constriction ring in order to maintain the erection. Used a lot in post-surgical pelvic floor surgeries and is a great device. There are 2 options, electric or manual. Depicted in the pictures, an electric machine. Some patients don't like it, but some patients find it very useful. And the last treatment option I want to discuss is a penile implant. These implants offer an option to achieve a good erection for patients who have failed medical therapy. There are 2 main options depending on your patient criteria. So a semi-rigid malleable, depicted lower in the picture, is always semi-rigid. It is a very useful device. There are only 2 rods inserted in the surgery operation, and they're good for patients that have a problem with fine motor skills. The 3-part implant has 2 cylinders that are implanted in the penis, a small pump in the scrotum, and a reservoir of fluid inside the abdomen. I will show a quick video in the next slide to depict that a bit more specifically. When a patient wants to inflate the penile implant, you can just do so through the pump in the scrotum. So this is the video. So looking here, you can see the penile implant has 3 pieces: the reservoir that has the fluid currently, the cylinders, and the pump. When the patient is interested in achieving an erection, uses the pump to transfer the fluid from the reservoir over here in the back to the penis here in the front. Now that we've covered treatment options, I want to tell you what I need to know. Some patients come to the clinic not knowing what their medical history, so things that are important for us: cardiovascular history. Are you taking nitrates? Nitrates interact with PD5 inhibitors such as Viagra and are not allowed to be taken together. Have you had pelvic surgery? Do you have glaucoma? Again, interacting with some of the medication we may prescribe. If you have closed angle glaucoma, I would like to know that about you, and if you're using a listed drug. So in conclusion, treatment for erectile dysfunction has many options. First and foremost, lifestyle changes, medications, pills or intracavernosal injection, vacuum device, or surgery for a penile implant. To know more, you can schedule an appointment with me or with any other urologist in the city and get some more information on what suits you. To take a quick turn and talk about vasectomies, I'm sure many of you have heard about vasectomies and may have had one done. It's the 4th most common birth control in the US and considered to be a permanent form of sterilization. It's very important to realize that it is a permanent form, although it can be reversed in the OR. It's a lengthy procedure with a complicated procedure to perform. It does not prevent STIs or STDs, and condoms still need to be used if you're not having sexual interaction with a single partner. The procedure is done under local anesthesia or sedation, takes about 30 to 60 minutes. The procedure does not change sexual function, erection, ejaculation, or libido, and there is a minor complication of 1 to 2% of bleeding, infection, or post-operative pain. Just a little bit about the post-operative time of the vasectomy. You need to rest for about 2 to 3 days. Icing the area is very useful. No exercise for 1 week. Ejaculation is not recommended for 1 week. And there's one major thing to forget: you're not out of the woods. Sterility needs to be proven with a post-vasectomy semen analysis about 2 to 3 months after the vasectomy, when everything is flushed out of the system. Thank you. I'm going to transfer over to our nurse practitioner, Lynn Motanya. Take us home, Lynn.
Lynn, you're on mute.
Hello, everyone. Just give me a moment here while I get the screen share on. This one is still in presenter mode.
Nope, looks perfect.
Oh, wonderful. Okay. Hi, everyone. My name is Lynn. I'm a nurse practitioner. I independently run a general urology clinic where I see patients for a lot of the various conditions we'll be talking about in today's webinar. I practice in Manhattan, specifically the Upper East Side location, which many of you may have been at. Prior to my current position, I attained my master's and then my doctorate of nursing practice at Columbia University. I then went on to work in urologic oncology at Lenox Hill Hospital for a few years and then transitioned to Cornell. Today, I'll be talking about specifically urinary frequency, BPH, and hematuria. So frequency is perhaps one of probably the most common urinary complaint that we get in the office. And it is defined as urinating more frequent than is normal. Now, a lot of people ask, what is normal? But the answer to that is quite subjective. What we've traditionally accepted as normal is urinating about 7 to 8 times during the waking hours, or about every 2 hours or so. But this varies very much based on one's fluid intake, their medications, their medical conditions, and more. A lot of people who come to the urology office with complaints of frequency are usually urinating a bit more often than that, sometimes every hour and a half, every hour. We even see patients who are urinating about every 15 minutes. It is rarely an isolated symptom. Rather, it's often associated with other lower urinary tract symptoms. And depending on the associated symptoms, it can help narrow or guide the diagnosis. For example, a urinary tract infection usually presents as frequency associated with like urgency and dysuria, which is burning when you urinate. And BPH, or enlarged prostate, while it may have some of those symptoms, it often is associated also with what we call obstructive symptoms. So difficulty urinating, having a weak stream or a stream that starts and stops, and difficulty emptying the bladder. These are some of the most common causes of frequency. Some are urological, others not. I would like to briefly point out carbonated beverages, because these are very popular nowadays, but not a lot of people are aware that excessive consumption actually contributes to a lot of urinary frequency. Diuretics are commonly known as water pills, or medications that can also cause a side effect. And some chronic conditions or conditions such as constipation, diabetes, sleep apnea, and neuromuscular and neurodegenerative illnesses such as Parkinson's, MS, and stroke. These can cause some changes in the bladder, leading to frequency and urgency, or even difficulty urinating. In terms of urological causes, urinary tract infections are high on the list. A syndrome of clogged overactive bladder, which we'll talk about in a few slides, BPH or enlarged prostate for sure. And inflammatory conditions of the bladder, such as radiation cystitis or interstitial cystitis, which you may have heard of. I also include in this list an inflammatory and infectious diseases of the prostate, prostatitis, and bladder prolapse or female pelvic organ prolapse. Next slide. Does that work? Okay. So what do you expect when you come to the urology office? One of the first things we do is just get a detailed assessment or history of the symptoms. We may do a physical exam, for example, to check the opening of the urethra, sometimes a prostate exams, or in a female, a pelvic exam may be necessary to assess, for example, for prolapse. You may be asked to fill out a questionnaire, or at the end of the visit, take home what's called a voiding diary, which essentially is to record your fluid intake and voiding amounts over the course of a few days. Certainly expect a bladder scan, which is just a quick in-office sonogram after you urinate to check bladder emptying. And likely, to no one's surprise, we will get urine testing. There's three main types of urine testing. A urine dipstick is just a quick in-office dip that kind of screens what's in the urine. It's not always done, but is useful in some clinical scenarios. For more formal urine testing, we send out for a urinalysis with microscopy and a urine culture. And the urinalysis or microscopic exam or microscopy is essentially taking the urine and looking at it under a microscope. And this will tell us what cells are in the urine and their quantity, including red blood cells. The urine culture is what we use to assess for infection, urinary tract infection, excuse me. I would like to briefly touch upon overactive bladder. This is like the syndrome of frequency, urgency, really in the absence of an obvious cause or obvious pathology. These patients will present to the office with complaints of constantly running to the bathroom. They have strong sudden urges to go to urinate. They may have difficulty holding in the urine when it's time to go. They may even leak if there's no bathroom nearby. The common thing we hear is, I have a sensitive bladder, or I've always been told I have a small bladder. It affects up to 27% of men and 43% of women, depending on the statistics you look at. So it's not uncommon, but there are various treatment options, including medications with good outcomes that can help alleviate the symptoms. Another condition that causes frequency in lower urinary tract symptoms is BPH, or commonly known as enlarged prostate. BPH stands for benign prostatic hyperplasia. And what it is, it's a proliferation or growth of smooth muscle and cells in the prostate, specifically the transition zone, which is this area here right beneath the bladder. While there's several theories why it happens, it's not exact, the cause is not exactly clear, but the symptoms generally start affecting men around the age of 50. I like this picture because I think it does a good job at showing the dynamics between the bladder, the urethra, and the prostate. On the left, or my left, you can see, what happened here? Sorry, on the left here, you can see a prostate without BPH. Notice the size of the bladder and the urethra, which is patent, allowing for smooth, unobstructed urine flow. And on the right is a little bit of an exaggerated but not inaccurate picture of BPH. And you can see that as the prostate enlarges, it pushes into the urethra, causing narrowing and obstruction, and can also push into the bladder. And all these symptoms cause what we generally see of BPH, the weak stream, trouble starting the stream. The stream may start and stop. You may have dribbling after. You can also have bladder symptoms of frequency and urgency. The bladder, to compensate for this obstruction, may start working harder to push the urine out and become accustomed to holding larger amounts of urine. The severity of the symptoms varies, but they're often progressive. And in patients who have significant enough obstruction over time and without treatment, those secondary changes in the force and the capacity of the bladder can ultimately cause weaker bladder muscles, causing what we call an underactive bladder. So for BPH, what you can expect in the initial visit is very similar to the previous slide: history and a physical and a questionnaire. We often use the IPSS, which stands for International Prostate Symptom Score. And this is just a 7-question screening tool for BPH symptoms. Again, there's that bladder scan to check if the bladder is empty. We may also use a uroflow, which does exactly what it sounds like it does, assesses the flow of the urine, and certainly urine testing to check for infections and whatnot. Some patients require further testing, especially if they have significant urine retention or not responding to first-line treatments. Very commonly, we do what's called a cystoscopy, which is a scope that allows us to examine the urethra, the prostate, into the bladder. And you can actually identify or see any narrowing of or prostate obstruction when we go through with a scope. Urodynamics or video urodynamics, there's a series of tests that examine the function of the bladder, urethra, and the sphincters, essentially how these store and release urine. It offers a wealth of information, and it's done by very specialized doctors and practitioners here in the practice. So there are various treatments for BPH. Briefly, I'd like to point out that some patients actually benefit just from what we call behavioral modifications. For example, if someone were to say, I'm getting up 3 times a night, and that's the only thing that bothers me, and they're emptying the bladder well, we may recommend just holding fluids a few hours before bed. Can go a long way to helping alleviate some of those milder symptoms. In terms of medications, alpha blockers are generally the first line. And these work by relaxing that musculature of the prostate. Medications include tamsulosin, or commonly known as Flomax, alfuzosin, and more. We also have 5-alpha reductase inhibitors, which is finasteride, and this works by shrinking the prostate. Downside is it does not work as quickly as the alpha blockers in relieving the symptoms. A daily Cialis has also been shown to improve BPH symptoms, and this is a good option in men who also have erectile dysfunction. A lot of patients are on a combination of these medications. Surgery is also an option and recommended for some patients, specifically patients who are not responding to medications, do not want to be on medications, have refractory urinary tract retention, or complications of BPH, such as urinary tract infections and bladder stones, among others. Lastly, we'll talk about hematuria, which is blood in the urine. And there are two different types of hematuria. Gross hematuria is visible blood in the urine, and microscopic blood is a red blood cell seen under a microscope. And that's where that urinalysis and microscopy comes in. Hematuria accounts for about 20% of urology visits, so we do see a lot of this. These are some of the common causes of hematuria: kidney stones, urinary tract infections, BPH, or enlarged prostate can actually contribute to blood in the urine. I include some less common causes here: trauma, in the outpatient setting, not as common, anatomic abnormalities, and malignancy. When we're talking about cancers of the urinary tract, specifically kidney and bladder cancer, one of the first and only signs can be blood in the urine. Therefore, any patient presenting with unexplained blood in the urine, especially visible blood in the urine, is considered at risk for malignancy and recommended to see urology for further workup. What is this workup? There's that history and physical again. We ask questions such as, when did the blood start? Is it visible, or were you just told that you had it on a urine test? Did you have any symptoms associated with it? We will get urine testing again, if not already done, but also again. And you'll get some sort of imaging. Commonly is a renal ultrasound or a sonogram, or a CT urogram, which is a CAT scan specifically of the urinary tract. Some patients will get an MRI. And lastly, a cystoscopy, which I include another picture of it again, and that's to look inside the bladder. Patients often ask, why do we have to do this invasive cystoscopy if we're already doing a CAT scan, which is pretty good. And the answer to that is just, while imaging is great, it can miss small things in the bladder that ultimately turn out to be bladder cancer. These are the American Urological Guidelines for hematuria, and they essentially guide us as to how we work the patient up. And what these guidelines say, in essence, is that any person who has visible blood in the urine is automatically put in this high-risk category, and they should get a cystoscopy and a CT urogram. If a patient is presenting with microscopic blood in the urine, then they're put into one of these three categories, either low risk, intermediate risk, or high risk, depending on their risk factors for malignancy. And these risk factors are things like age, family history, smoking history. And where they fall on that, which category they fall in essentially determines if, for example, we just get a sonogram or we do a CAT scan. Lastly, I'd like to point out that we don't always find a urological cause of blood in the urine, but we will have done our due diligence. And keep in mind, there are non-urological causes such as medical renal disease, but certainly it's recommended for anyone with blood in the urine to see urology for a workup. Thank you. I will now turn it over to Dr. Winkler, who will finish us up.
All right, thank you, Lynn. That was a lot to cover a short period of time, so I applaud that. Okay. All right, so this is a picture of me on a really good day. I'm chief of urology in Brooklyn. I did my residency at Albert Einstein. I see patients primarily in Brooklyn, but I also see patients on the Upper East Side, the same campus as my two colleagues, and I am a general urologist. A particular passion of mine is community health awareness of urologic disease. I was at a community fair in Brooklyn this past Sunday, just meeting people and just talking about what I'm about to talk about in these next slides. Next slide. So we can actually go to the following slide because Lynn covered this. All right, so this is a little bit graphic, a little figuratively and literally, but this is a cross section of the prostate. And as Lynn mentioned, the prostate is broken up into different zones. And I put this up here to really say that the majority of prostate cancer happens at the edge in what's called the peripheral zone. A relatively small part of it happens near the urethra. And I mention that because when prostate cancer is localized and at the very beginning, it's really not going to cause much in the way of symptoms. The part of the prostate that tends to most likely harbor prostate cancer cells really isn't near the urethra. And because of the location of the prostate being very deep in the pelvis, it's a challenging organ to examine, which is why we often rely on a blood test as the first evidence of who we should be concerned about having prostate cancer. Next slide. So there are a few things that happen to all men to some degree, or can happen to all men to some degree, as time goes on. As Lynn mentioned, benign enlargement, which on a microscopic level actually can happen in the 40s, but those microscopic levels don't add up for at least another decade or decade and a half to be enough to impact your urine in terms of you noticing changes in your urination. You can have inflammation in the prostate, prostatitis. We tend to start to see this in a younger population than BPH, sometimes 20s and 30s, but you can have that even into the later decades of your life. And also possibility is prostate cancer. Next slide. So prostate cancer screening is a super controversial topic. And I am not a urologic oncologist, but people who see general urology patients are often the first decision makers or the first people to give guidance to people with elevated PSAs. And there very specifically was a backlash because there was a belief that too many people were getting this blood test, and the blood test wasn't being used properly, and too many people were getting prostate biopsies, which sort of made the pendulum swing in the opposite direction. So there is a lot less screening, fewer prostate biopsies, but unfortunately this, and sort of combined with the double whammy of people not having access to care as they normally would during COVID, has left us in a situation where for the last few years, we're just seeing more poorly differentiated, which is another way of saying aggressive cancers that we have in previous years, and more people who are being diagnosed with metastatic disease. So what can you do to stay out of this category? So next slide. You can at least begin the discussion with your patient, with your physician rather, or your care provider about whether or not a prostate cancer test, namely a PSA, is the right test for you. So these are some of the things that urologists or people who see urology patients think about in terms of getting a PSA blood test. It's not a test that we order blindly, or really anybody should order blindly. And we really start by thinking, is this the right test for this patient? Is the patient a high-risk patient? If we have a patient that's sent to us with an elevated PSA, or if we draw an elevated PSA on a patient and it happens to be abnormal, are there other causes? So one of the most common causes for an elevated PSA is a urinary tract infection, or someone who's had some sort of instrumentation of their urinary tract. So Lynn showed a couple of slides of folks having cystoscopy, or a telescope was put in the urethra past the prostate, or having a urinary catheter. These can all temporarily raise the PSA. And this is all, things that if we are really keen on trying to explain this, so that patients are not so worried about an abnormal test result. And is there really a difference in terms of age and who should get this test? Do we look at this test differently from a 52-year-old versus a 72-year-old? So next slide. So one of the great things that have helped us use PSA in a more efficient way is some of the tests that are adjuncts to PSA. So a huge one, really, that's come about, I would say, 10 years, and really in particular the last 5 years, is getting an MRI of the prostate. So essentially, if people have an abnormal PSA, and oftentimes will repeat it to really verify that it's truly abnormal, they'll essentially always, if they can, get an MRI of the prostate. And most people can, unless they have some sort of metallic implant that prevents them from getting MRIs in general. So an MRI is great in sort of two directions. One, it can give us a great explanation for why someone may have an elevated PSA. So one common one is just having a markedly enlarged prostate. So the bigger your prostate, the more PSA it's going to generate. So what may be abnormal for one person may not be abnormal for you. There's also sort of a grading system of MRIs from 1 to 5. So if you're in a category 4 and 5, and possibly in 3, there's usually an area of your prostate that there is concern for having prostate cancer cells. There are other blood tests and iterations of PSA that we use so that we can use it more efficiently, including free PSA, PSA density, and PSA velocity, which is a measure of how quickly your PSA rises. Next slide. So again, as I said, this is a super, super complex topic. So I wanted to simplify it for you in terms of how you should think about it. And to some degree, you may have to be a little bit of an advocate for yourself in asking for this test. So if you are low risk, and it's worth asking your primary care provider about just getting a baseline PSA test between age 45 and 50. If you're high risk, you should think about asking for that baseline test earlier, between age 40 and 45. So what do we consider high risk? So high risk is being a person of African descent. African Americans have the highest risk of prostate cancer essentially in the world. Also, if you have a family history of prostate cancer, so that's a male relative, father, brother, uncle who has had prostate cancer. Also, if you have a family history of hereditary breast or ovarian cancer, you can be considered high risk. So it's important to know your history, and it's also important to know your family history. In general, after the fourth decade, in the 50s and 60s, you should be screened between age 50 to 69 at minimum every 2 to 4 years. So this is a guideline recommendation. I can tell you the overwhelming majority of the patients that we see get screened yearly. And screening, and this is super important and a big change, screening is now a blood test. We've eliminated the rectal exam, so that's essentially, to be specific, an exam where we put our finger in your bottom to try to examine that peripheral zone of the prostate, which isn't a terribly efficient way to examine the prostate. That's been eliminated. All right. So really, it comes down to speaking to your care provider about getting a blood test. Next slide. Even with a family history of prostate cancer, or even if you're high risk, we don't recommend screening under the age of 40. Next slide. And there's not a recommendation of routine screening in men after age 70. Now, I have a number of men who after age 70 continue to be screened But this is one of the groups where it's important that it's a discussion. And it has to, as what we discussed with a lot of the different topics that my colleagues discussed, it's a matter of your general health and a matter of your preference. And also a matter of whether or not you would accept treatment were you to be diagnosed with prostate cancer. Next slide. All right, I think that's it. I wanted to just talk about that small topic and leave time for questions for the group.